Good morning, everyone, and welcome you all to the third day of our Congress, the last day. We have one very important session coming up, that is the selection of the best trainee paper, best paper presented by a surgical trainee. Today we got 7 presentations to go. So without further ado, we'll get on with the presentations. First presentation needs to be done by Dr. S. Tivaga on intralesional versus oral steroid treatment for idiopathic granulomatous mastitis. It's over to you, Dr. Tivaga. Just a small reminder, each presenter will get 6 minutes and for the presentation and 2 minutes for questions.
Recording in progress.
Good morning, Chairperson, judges, ladies and gentlemen. Our study is titled Intralesional versus Oral Steroid Treatment for the Idiopathic Granulomatous Mastitis. Idiopathic granulomatous mastitis is a benign inflammatory breast disease. It affects the women of childbearing age and commonly seen in Mediterranean and the Asian region. The etiology of the disease is still hypothetical. And this is a recurrent and mutilating disease, as in these pictures of our own patients. Unfortunately, there are no standard guidelines for treatment of IgM, but oral steroid is a commonly practiced method to treat the IgM. The biggest drawback of the long-term oral steroid use is the potential side effects. Due to these things, recent studies have emerged on the use of intralesional steroid and whether this can reduce the side effect. When we look at the Sri Lankan setting, there is minimal data on the epidemiology and management of the IgM. It is in this setting that we have described the clinico-pathological pattern of the IgM in patients treating with the intralesional versus oral steroid. And we compared complete clinical response, side effect, quality of life, compliance, and cost effectiveness in the intralesional versus oral steroid groups. We compared the intralesional group prospectively with oral steroid group retrospectively. In the intralesional group was administered with the triamcinolone and the oral steroid was given with the methylprednisolone. Our study population includes all the patients with clinical and histological diagnosis of the IgM. The primary outcome of our study was complete clinical response, which is defined as complete disappearance of the symptoms clinically and radiologically at least for 1 month. This definition was taken from the published literatures. The data collection includes clinical, radiological, and pathological data, and interviewer-administered questionnaire used for the socio-demographic and WHO BREF questionnaire for the quality of life. And for the compliance, we used direct observation therapy and medication adherence report scale 5. Ethical clearance was obtained, and since our data is restricted to a small sample size, we used non-parametric test for the statistical analysis. And we calculate the statistics accordingly. When we come to the results, in the patient population characteristic, there were 17 patients in the intralesional group and 22 patients in the oral steroid group. Mean age, breastfeeding time, parity were almost identical in both groups. We compared the clinical and radiological characteristic. The commonest symptoms were mastitis and mass, and also abscess, fistulation also there. Both groups had similar symptoms with no statistically significant difference. Next, we compared the time taken for the complete clinical resolution. We observed a faster response and shorter treatment duration in the intralesional compared with the oral steroid group. However, it was not statistically significant. All the patients in the oral steroid group had at least one systemic side effect, where in the intralesional group had no side effect. Then we come to the compliance. Absolute compliance was noted 88.2% of patients in the intralesional group, and while only 54.5% of patients in the oral steroid group. This was statistically significant. And the mean cost per person for higher in the oral steroid group. We assessed the quality of life under 4 arms of the WHO brief questionnaire, and we noted significantly low quality of life in the physical, psychological health in the oral steroid group in comparison to the intralesional group. This one is indicated by the arrows. And this is probably attributed to the systemic side effect of the oral steroid. We performed an extensive systematic review on this topic and found only 3 comparative studies, 2 RCTs and 1 retrospective study, and our results also comparable to those studies. Our study is first study to have conducted in South Asia, and also first study we analyzed quality of life, which we think which is very important because our population consists of young mother with debilitating disease. In conclusion, intralesional group has similar efficacy to treating the IgM as oral steroid. More importantly, in our setting, this is minimal side effect, improved quality of life, better compliance, and cost effective. So we recommend intralesional steroid as a promising option for the IgM treatment. Limitation of study. Our study had a short-term follow-up for 6 months, and we did not assess the long-term outcome, including the recurrence. As this is an ongoing study, we will address those limitations. Thank you very much.
Thank you, Dr. Tivaga, for sticking to your time as well. Now the paper is open for discussion. If there are any questions from the floor.
Good morning, Rowan Parks from Edinburgh. Thank you for a very clear and very well presented study. Can I ask the choice of therapy and how that decision was made, and particularly any differences in the extent of the disease, the size of the lesion between the two, and also the chronicity? Was there any difference between the 2 groups?
No. Thank you very much, sir. In the both group, we choose the patient with that.
I guess I'm trying to understand, were there any differences in how the decision to give intralesional or oral steroids, was it based on the size, the extent of the lesion, the chronicity of it, or was it? It wasn't a randomized trial, but how was that decision made?
Yes, this is, we gave that intralesional and the oral steroid depending on the size of the lesion. This is more than 5 centimeter, we considered as the high dose steroid, and less than 5 centimeter is less severe symptoms. We gave less doses for that.
Are there any more questions from the floor? Okay, if there are no more questions, thank you, Dr. Tivaga. So the next presenter is Dr. Oshan Basnayaka, who's going to present on comparison of aesthetic outcomes of simple interrupted suturing with combined dermal and subcuticular suturing in pediatric facial laceration suturing. Over to you, Dr. Basnayaka.
Thank you. Good morning. So our study is comparison of aesthetic outcomes of simple interrupted suturing with combined dermal and subcuticular suturing in pediatric facial lacerations. Facial lacerations are a common encounter in an aesthetically important area, and management of a complicated scar is difficult in surgical practice. And suture removal without sedation or general anesthesia is a unique problem in pediatrics. So the objective of suturing is to achieve the primary healing of the skin. So in our intervention, we had 2 groups. Modified suturing groups were sutured with dermal plus subcuticular suturing, as you can see in figure A and figure B. The traditional suturing group, we use simple interrupted sutures as described in figure C. In both groups, we used rapidly absorbing polyglycopron 6-knot sutures. For the objective assessment, we use Stony Brook scar evaluation scale, where we consider the width of the scar, the height in relation to the surrounding skin, the degree of pigmentation, and presence or absence of suture marks. We included all clean facial lacerations with full thickness dermal involvement. As exclusion criteria, we excluded patients who had significant tissue loss post or pre-debridement causing tension after the tissue closure. And the patient who presented 24 hours after the injury because they are at a higher risk of infection, and surgical site infection during the follow-up period of 1 month. During 5 months study period, we recruited 149 patients with average age of 5.7 years. And figure 1 shows female predominance in our group, and figure 2 shows predominant mechanism of injury as accidental falls. So we had 72 children in our modified suturing group and 77 children in traditional suturing group. In both groups, the forehead and chin were involved in majority, reflecting the area of maximum impaction. Regarding the depth of laceration, in both groups, the majority had muscle involvement, and comparatively higher involvement in deeper layers were seen in modified suturing group. The mean scar assessment scores were 3.86 versus 4.93, and we analyzed the skewness and kurtosis, and we showed that both groups, the data was skewed, and so we used non-parametric Mann-Whitney U test for statistical analysis. So in comparison, the comparison showed statistically significant difference in scores showing superior aesthetic outcome in modified suturing group. In a subgroup analysis, the results showed prominent difference in scores were related to suture marks in simple interrupted suturing, and rapidly absorbing sutures were retained for about mean duration of 23.4 days, ranging from 14 to 38 days. So in discussion, the strengths are, this was the first study to compare the two types of suturing in local setting. So we had several limitations. This was a non-randomized trial without sample calculation, and we didn't assess the long-term outcome, but it depends on many factors such as the skin type. Patients or parents' perspective was not included, and learning curve for proper dermal approximation is longer, and comparatively there's higher operative time, which was also not assessed. Even though we excluded surgical site infection, the low rate of surgical site infection was noted in both group, 2.5%, and we didn't analyze the cost effectiveness. These are some of the examples. As you can see, this is the modified suturing group, pre-operative, intraoperative, and 1 week post-operative. Similar case, pre-operative, 1 week post-operative, and 2 weeks post-operative. So this is a result of simple interrupted suturing, pre-operative, and 2 weeks post-operative. As you can see, there are sutures still remaining. So in conclusion, superior short-term cosmetic outcome can be obtained by dermal suturing combined with subcuticle suturing. And this technique circumvents the problem of suture removal as well. So further studies are needed to generate a generalizable results with overcoming above mentioned limitations. So we did a literature review where there's a randomized trial comparing continuous versus interrupted suturing in facial surgery. But the differences are, it is in the adult age group, they have used non-absorbable sutures, and both sutures were removed in 2 weeks' time. And there's a systematic review which was published last year. They have compared running versus interrupted suturing. So dermal or subcuticular suture, they had superior outcome. But the issues were, they were in adult population, only 3 studies were included in facial laceration suturing. And it has not combined dermal plus subcuticular suturing. So it used dermal or subcuticular suturing. So thank you for listening.
Thank you, Dr. Basnayaka, for that presentation. Now the presentation is open for questions from the floor. Can I ask a question now? You said standard suture removal is done in 2 weeks, but...
So in pediatric age group, we don't remove sutures, sir. Because the problem is...
interrupted sutures, you just leave them.
That's why we use rapidly absorbing sutures, but the problem is even though they say the manufacturer claims that it's absorbed in 7 days, we have noticed that it persists for 23 days. So that might be the reason for the persistence of these hatch marks and suture marks, sir.
Are there any other questions from the floor? Okay, in the absence of further questions, thank you, Dr. Basnayaka. We move on to the third presentation of the session. It is to be done by Dr. Dishan Samaratunga on comparison of traumatic amputations, patterns of upper limb, and success of reperfusion in plastic and reconstructive surgical department. Over to you, Dr. Samaratunga.
Good morning, ladies and gentlemen. First of all, I would like to thank for the opportunity given to present our paper in this session. Our study is titled Comparison of Traumatic Amputation Patterns Related to Upper Limb and Success of Reperfusion among patients presented to our unit, which is a Plastic and Reconstructive Surgical Department of National Hospital of Sri Lanka. Traumatic amputations of the upper limb are a relatively common type of injuries which are presented to our department, and it causes a major impact on the functional status and the psychology of the patients. So replantation is defined as reattachment of a completely amputated body part, where revascularization is the re-establishment of the blood supply of an incompletely amputated body part. The outcome of replantations and this type of revascularizations depend on the injury pattern and the expertise of the managing center, which is the surgical procedure itself and the further therapy they undergo. So the objectives of our study was to identify and compare patterns of injuries related to the traumatic upper limb amputations, and to describe and compare the outcomes, viability outcomes of our replantations. It was a prospective study. Patients were recruited on admission, and admissions and transfers to the National Hospital of Sri Lanka, Colombo, from January 2022 to June, and the other cohort was in the next year, January 2023 to June 2023. And we analyzed the data on, it was sort of a descriptive study. We analyzed the data on demographics, the injury pattern, and the 30-day viability outcome. Regarding the injury pattern, we had 1,486 traumatic total admissions, out of which 51 were traumatic amputations in the first year, 2023-22. In the next following year, we had 908 upper limb injuries, out of which 30 were traumatic amputations. And out of those, the major proportion were due to machinery cuts, which were mostly the rotating grinder and the oscillating grinders, which comprised more than 50% of our presentations. And the next common type was the sharp cuts, which were knife cuts, and mostly due to interpersonal conflict. And about 5% were avulsion injuries. Talking about demographics, the mean age was around 34.3 years, which is the main workforce of the country. And there was a significant male predominance of 86%. And the dominant hand was mostly affected in most cases, at 67%. Regarding the anatomical classifications, the most were at the level of the phalanx, at the zone 2 level. And the next commonest were at the level of the wrist. These are total amputations. And forearm and metacarpal levels are much less. So about 60% of our admissions were at the zone 2 level. And again, in more than 50% patients, multiple fingers were affected, and the thumb was affected in about 40% of patients in both years. Regarding our management patterns, we performed reperfusion in 27 patients in 2022, that 6 months, and 20 patients in 23. The reasons for not attempting revascularizations we analyzed, most were due to crush injuries, where we thought that the vessel conditions will not be adequately healthy to perform an anastomosis, and some were multiple level cuts, and others were unstable patients, polytrauma patients, where major reconstructive procedure was not indicated. So the outcome data, we analyzed the 30-day success rate. We got down the patients. It was a physical analysis by our therapist and us. And we noted that the success rate was 70% in both years. And the causes of failure we analyzed, most were due to venous congestions, that is around 75% in the first year and 83% in the second year, and few were due to arterial insufficiency. We didn't notice any loss due to infections. So a little bit about the technique we used. In the digits, we use a one artery, two vein anastomosis. If they are freely there, we do a bit more dorsal veins, more veins are better. And in the hand, we do a one artery plus a deep vein and few superficial veins. And in most cases, the skeletal fixation was from K-wires. And in some cases, we did, with the help of our orthopedic colleagues, did the plating. So the conclusion was our unit success rate, which was around 70%, was comparable with other centers and was consecutive in both years. Further improvement can be achieved by analysis of our failed cases. These are a few examples that we performed last year, which was first one is a thumb amputation, second one at the wrist level, the third one is a fingertip amputation where we only use artery-only anastomosis. Next one was a zone 2. And the fifth one is, again, it's not a sharp cut, but we tried and it worked, where we shortened the limb a bit and, yeah, thank you. So, open.
Thank you, Dr. Samaratunga, for the presentation. Now the paper is open for discussion.
Thank you for a very interesting presentation. Horrific injuries, lovely illustrations. Can I ask why you compared the 6 months in 22 to 6 months in 23? Was there any change in approach or technique? Why did you do that comparison as opposed to just reporting the case series and your outcomes?
The one thing was, this is a little, the data on these presentations are not available for Sri Lanka, and most cases come to our hospital, the National Hospital of Colombo. These two were done by two teams, and we wanted to analyze our results as a unit progression, how our techniques are there. And we would like to further analyze the results of our functional outcomes also, which is a bit of like a limitation in this study.
Yeah. I was going to, as a follow-up, if I may.
Yeah.
So you say the success rate was 70%. What is the definition in this study of success? Because you don't have that functional data, but what would...
It was the viability assessment, most like whether it's a failed replantation or a successful replantation with the viability wise. And we would like to further continue this study to get a functional outcome. We had to follow up more than 2 years because the therapy takes a little bit of time to get.
Sure. Thank you very much. Thank you.
So, are there any...
Same question in a different way. What changed between the 2 years? What are you trying to look at? Why the two periods? Why not one continuous period? Or why not pool the data and report it as...
Yeah, because this
what changed in that two periods?
These surgeries take a lot of time, and a lot of the learning curve is also high. So we wanted to see whether there's any improvement or whether there are places where we can...
Okay, thank you, Dr. Samaratunga. So the next presentation is on long-term outcomes of phrase procedure for chronic pancreatitis, a single sentence experience to be presented by Dr. S. Harikrishant. Over to you, Dr. Harikrishant.
Good morning to you all. I am Dr. Harikrishant. I am going to present a study which is a single center experience, a long-term outcome of phrase procedure following chronic pancreatitis. So chronic pancreatitis is a progressive inflammatory disorder characterized by irreversible destruction of pancreatic parenchyma associated with disabling chronic pain, permanent loss of exocrine and endocrine function. And the surgical treatment of chronic pancreatitis is indicated for intractable pain. So phrase procedure is an acceptable method of treatment of choice in this disease. And the aim of our study is to determine the long-term outcome after phrase procedure. So the methodology that we use, this is a retrospective study conducted among patients who underwent phrase procedure between April 2018 to April 2020 at University Surgical Unit, Colombo South Teaching Hospital. And a long-term, that means more than 3-year follow-up was performed by conducting in-person interviews in 2023 February. In regard to the patient demographics in the outcome of these studies, total 11 patients underwent this surgery, and we lost 2 from follow-up. And the mean age at the time of surgery was 38.44, and out of them, 77.8% of patients are non-alcoholic. And out of them, 55.6% of patients underwent preoperative pancreatic stenting, and rest directly went for surgery without stenting. In regard to the pain assessment, the mean pain score out of 10, it was 9.22 before surgery, and which was 1.33 after surgery, which was statistically significant with a p-value less than 0.05. And in regard to the pain assessment, again, and all the patients needed opioid analgesics before surgery, and while none required after surgery, none required opioid analgesics after surgery. And in regard to the pancreatic function, in regard to exocrine function, after surgery, the weight gain that obtained was 44.4%, and good appetite was noticed in 77.8%, and reduced bowel frequency was noticed in 66.7% of patients. And it indicating that none of them, they are having not to have an exocrine failure. And in regard to the endocrine failure, which has slightly increased from 22.2% to 44.4%. You can see the blue pole of the graph, that which indicates the need of insulin after surgery. In regard to quality of life, we assess the quality of life using SF36 score, the mean score for different domains, as 95% for physical functioning, 86.11% for physical health limitation, 88.89% for emotional problem limitations, and 73.33% for energy or fatigue, and 84% for emotional well-being, 90.28% for social functioning, 92.78% again for pain, and general health score was 65. So these mean score indicates a good quality of life following surgery. In regard to the surgical complication, we had 1 patient out of 9 had surgical site infection, but we didn't get any other major surgical post-operative complications. So before coming to the conclusion, the limitation that we had is the sample size is 9. So we had taken the data for about a 3-year period. We have done 9 cases. 11 cases, 2 we lost the follow-up. So in regard to the conclusion, the significant pain relief and good quality of life after phrase procedure is observed, and preservation of pancreatic function have been noted, and there is a low complication rate. Thank you.
Thank you, Dr. Hari Krishant. Now the paper is open for discussion.
Thank you for, again, another very clear, well-presented study. Can I ask, what was the main etiology of the chronic pancreatitis? I think of the 11 patients, 78% of them were non-alcoholic as an etiology, which would be very different from a population in the UK where the vast majority of them, the disease process is due to alcohol. What's the etiology in Sri Lanka?
We also get the majority of patients are alcoholics, but the patients in this study included that most of them are non-alcoholic. The inclusion criteria for the surgery that we got was those who are having significant pancreatic duct dilatation, more than 7 millimeter duct dilatation with multiple impacted stones. So out of them, most of them are non-alcoholic.
Can I just ask you something to clarify? You said this was a retrospective study and you had done 11 procedures.
Yes.
But then you say, if it's retrospective, what were you looking at? The notes, or what exactly were you looking at? What were you interrogating to get your data? Is it the notes, patient's notes, or how did you get the data?
I couldn't get you, sir.
So you said it's a retrospective study.
Yes, sir.
So your data collection method, what was it? Looking at, retrospectively looking at the notes?
We
or
are
interviewing the
maintaining a
patient?
database in regard to these surgical procedures, and we called them this year February, and we had an in-person interview, and we collected the data from them.
So 2 out of 11 patients, you couldn't follow them up?
Yeah.
Are there any more questions from the audience? Okay. If there are no more questions, thank you, Dr. Harikrishnan.
Thank you.
We'll move on to the next presentation, that is outcomes and quality of life among chronic pancreatitis patients in a tertiary care center in Sri Lanka, to be presented by Dr. B.D.M.R. Chandragupta.
Very good morning to all of you. I am Minidu Chandragupta. So my research is on outcomes and quality of life among chronic pancreatitis patients in a tertiary care center in Sri Lanka. So just to give you a brief outline what chronic pancreatitis is, it's a progressive and permanent destruction of pancreas, which is associated with long-term and often debilitating complications that can considerably affect the quality of life. And the reported median survival in literature is around 15 to 20 years. And just a brief touch upon the quality of life. So it's an integral characteristic of patients' physical, emotional, social functioning. There are several domains to quality of life, which were analyzed based on the subject's subjective perception. So in literature, there are recognized complications that affect the quality of life. One of the highlighting feature being the chronic pain. Chronic pain has different outcomes, which can be very debilitating to chronic pancreatitis patients, followed by endocrine failure, extrarenal failure, pseudocyst, as you can see in the list. So we did a descriptive cross-sectional study in the University Surgical Unit of Colombo South Teaching Hospital from January 2020 to December 2022, where all patients with clinical and radiological features suggestive of definitive or probable chronic pancreatitis were recruited. And the patient population is around 112, and we subdivided them based on the intervention modality we have offered them into endoscopic, surgical, and conservative group. And the risk factors and quality of life between 3 groups were cross-analyzed. So we used the European Quality of Life Assessment Questionnaire, EQ5D5L, with UK index values. It is translated into Sinhala and Tamil, and interviewer or self-administered questionnaires were used. And the difference among these 3 intervention groups were categorized. As you can see, the questionnaire is very simple and easy to deliver questionnaire. It has 5 domains: mobility, self-care, usual activity, pain, discomfort, and anxiety depression. And the patient is allowed to mark or rate between 1 to 5, 1 where you have no problem, and 5 where you have a severe problem in each of the 5 domains. Moving on to demographic analysis. In here, what I want to highlight is that there is a mean number of 3 medical centers where a patient have taken treatment prior to ending up in a tertiary care institution where chronic pancreatitis is handled. And also there's a mean delay of diagnosis of about 4.7 years, roughly 5 years. We just briefly analyze our risk factors also. As always, as obvious, alcohol is the predominant risk factor. Regarding complications, most of our population has persistent abdominal pain as the most dominant complication, followed by loss of weight, persistent dyspeptic symptom, and so forth. So we went on to analyze which of these complications will impair the quality of life the most. And we found out that persistent abdominal pain and obstructive jaundice have a significant impact to the quality of life, as you can see in the chart. And then we went on to analyze which of the interventional groups are most affected by the quality of life. And then we found out in overall perspective, surgical group has a poorer quality of life compared to ERCP and conservative group. So, and then we went on to analyze which domains are being affected in each of these 3 groups. And we found out that self-care, pain, discomfort, and anxiety and depression seems to be one of the key highlighting areas that are affected in these three groups. Surgical group being more predominantly affected compared to ERCP and conservative group. Then we went on to analyze where is there a relationship between the complication and the domain of quality of life that is being affected. So as you can see here, which I have highlighted, some of the domains like anxiety, depression are mostly affected in patients having persistent dyspeptic symptoms. And you can see that loss of appetite is associated mostly with mobility component. Loss of weight has an impact on anxiety and depression, and so forth. Regarding the oral conclusions, we have come to a conclusion that chronic pain and obstructive jaundice significantly affects the quality of life among chronic pancreatitis patients. And overall quality of life is worse among patients who are offered surgery with significant effect to self-care, pain, anxiety, and depression. We think that this decrease in quality of life as the level of intervention escalated from conservative to endoscopic is likely because of the increase in severity of disease, delay in presentation, and multiple centers of treatment prior to ending up in a tertiary care institution. So we recommend that assessment of quality of life and early intervention to patients are recommended. We can also refer patients with chronic pancreatitis early to a tertiary care institution, and MDT assessment with objective assessment and monitoring of quality of life in chronic pancreatitis patients will help to optimize the quality of life among chronic pancreatitis patients. Thank you.
Thank you, Dr. Chandragupta. Now the paper is open for discussion.
Thank you for another excellent presentation. So can you tell me when the quality of life assessment was undertaken in relation to the therapeutic intervention?
So we analyze the quality of life at the end, as in these patients have been presenting from 2020 to 2023. So we analyze them. We have MDT clinic where we decide on the management option, and at the end we give them a descriptive value as we're going to manage you conservatively, endoscopically, or surgically. So at that point we took the quality of life assessment from those patients.
So before they had the intervention, was it used as a means of determining the intervention, or was it done after they'd had their surgery, after they'd had ERCP?
Yes, after it was done.
And at a variable time point, or?
No, it's like this. The patients who were being analyzed from 2020 to 2002, at one point, we have delivered their questionnaire once their intervention is over. And then we analyze. At
a fixed time point, or
yes,
just at a fixed, so how long after the intervention was the quality of life assessment done?
Generally after 1 year, 6 months to 1 year.
Can I ask you a question? When the way you presented the data, you suggest that if someone was managed conservatively, they never had endoscopy, or they never had endoscopic intervention, or they never had surgical intervention. But subsequently, you sort of indicated that they moved between the groups.
Yes, sir.
So was it a watertight compartment, or did they move between
No,
treatments?
no, they moved between compartments. And ultimately, where they end up is what we took, whether they went into endoscopic arm or to the surgical arm.
Thank you, Dr. Chandragupta. Next presenter is Dr. Umesh Jayaraja, who's going to present on low-risk thyroid cancer in Sri Lanka. Are we overusing radioiodine? Over to you, Dr. Jayaraja.
Good morning, chairpersons and ladies and gentlemen. This study is titled Low-Risk Thyroid Cancer in Sri Lanka. Are we overusing radioiodine? Thyroid cancer has become the second commonest cancer in Sri Lanka, and it has been shown to have a rising incidence according to our publication in 2020, and it is mostly due to differentiated thyroid cancer. And surgery is the primary treatment modality. Differentiated thyroid cancer has an excellent prognosis. Even at 30 years, there is 90% survival. Post-operative treatment includes radioiodine therapy and TSH suppression. Radioactive iodine is effective for the treatment and ablation of residual disease. However, it is associated with greater cost and also side effects. According to the American Thyroid Association guidelines, it was recommended in 2016 for high and intermediate risk cancers only. However, a landmark paper was published in 2022. Although there was previously, it was only based on cohort study, there was a randomized control study which was published in the New England Journal of Medicine, which showed non-inferiority in those treated without radioactive iodine compared to those treated with radioiodine. They looked at 3 years, the events, that is, any structural or functional evidence of recurrence, which was quite similar in both groups. So despite this study, there have been other publications that have shown that the use of radioactive iodine has been quite high. In USA, it was around 25%. So we decided to investigate the patterns of the use of radioactive iodine in thyroid cancer patients, and also to compare the use of radioactive iodine and delays in treatment between low risk and other risk groups. So it was a cohort study including a total of 2,600 patients, out of which 1,000 patients were low-risk patients. So we collected the data from differentiated thyroid cancer who underwent total thyroidectomy and who had a histological confirmation over a period of 7 years. Low-risk cancer was defined as T1, that is less than 2 centimeters, without any lymph node or any metastatic deposits, or any unfavorable histological features. It was a retrospective analysis of a prospectively collected data. And statistical analysis was performed using student t-test with a significance at 0.05. So in our population, we found that T1 disease was seen in 50% and N-node disease was seen in 83%. So the majority were good prognosis cancers. When comparing the radioiodine use between the low-risk and high-risk cancer patients, if you can note in the group where in the low-risk cancer group, around 60% received radioiodine, compared to in the high-risk group, 70% received radioiodine. So there is a very high percentage of population receiving radioiodine in our population. So this figure shows a trend in the usage of radioiodine in low-risk and high-risk patients. If you see, although there is a higher use of radioiodine in high-risk patients, in low-risk patients also there has been a considerable use throughout the years. Next, we looked at the treatment delay. So compared to the low-risk group, the high-risk group had a greater treatment delay, so which is significant statistically. And we looked at the trend, whether the delay was found throughout the years. If you can see, throughout the years, the moderate to high-risk patients had a greater delay compared to low-risk population. So in conclusion, in our population, that is in Sri Lanka, there was a significant overtreatment with radioactive iodine in low-risk thyroid cancers. And it probably resulted in longer delays in treatment, more so in the intermediate and high-risk group compared to the low-risk group. And avoiding radioactive iodine in low-risk thyroid cancer is likely to reduce costs, minimize unnecessary side effects to the low-risk population, and reduce delays for the truly deserving patient who has moderate to high-risk disease. So, this study is very relevant in the Sri Lankan population because the thyroid cancer is rapidly rising, especially the differentiated thyroid cancer, and it is causing a major burden in the cancer treatment sector. And it is the first study to be conducted in Sri Lanka. And simple intervention of avoiding radioactive iodine for low-risk cancer is likely to improve the outcomes in terms of cost and also side effects of patients, and also improving the treatment delays for the deserving patients. So this leads us to the concept of low-hanging fruit. So there are interventions that are high-lying fruit that may be too expensive for Sri Lanka. However, if you really closely look at it, there are cost-effective interventions that if we really look, we could find. So this is one such intervention. If we educate the clinicians and oncologists, it is likely that the overall cost and also the outcomes are likely to be improved. Thank you very much.
Thank you, Dr. Jayaraja. Now the paper is open for discussion.
Again, very clear presentation, lovely slides. I couldn't quite catch the measurement of the delay. Was it in days or was it in weeks? And you said it was statistically significant, but was it clinically relevant? What was the delay?
So delay in low-risk patients was around 7.2 months. That is the mean delay.
Months, okay.
Yes. In moderate to high risk, it is actually 8 months. It is greater than the low-risk group.
Okay. And do you have any national guidelines about who or who should not get?
So that is the current problem. We do not have accepted national guidelines. So that is the next step. So we have to use these findings to cater the national guidelines so that the treatment-related disparity should be minimized in our thyroid cancer patients.
Thank you.
Thank you very much.
Are there any other questions? We have 1 minute left. Okay, if there are no more questions, thank you, Dr. Jayaraja, for your presentation. Now we have come to the last presentation of the session, that is to be presented by, again, Dr. B.D.M.R. Chandragupta on surgical performance anxiety and mental well-being among postgraduate surgical trainees in Sri Lanka.
Good morning to all of you. So my presentation is on surgical performance anxiety and mental well-being among postgraduate surgical trainees in Sri Lanka. So just to give you a brief introduction on what performance anxiety is, it's a specific form of phobic anxiety as described in the International Classification of Diseases. And it's primarily been analyzed in musicians and athletes, and it has been rarely analyzed among surgeons. In 2022, there was a groundbreaking study in UK regarding the analysis of surgical performance anxiety, which concluded that there's high prevalence of SPA in all specialties and at all levels of experience. So understanding the performance-related anxiety and its impact on surgical outcomes is vital. So no study has been done up to date to analyze the SPA and its effects in a Sri Lankan setting. So we thought it is high time that we should study its prevalence, nature, potential impact, and mental well-being among our postgraduate trainees in Sri Lanka. So it's a cross-sectional study where we use the surgical performance analysis using the SPA inventory adapted from that previous study, and mental well-being been analyzed by the Short-Warwick-Edinburgh mental well-being scale. The study was conducted mainly on pre-MD surgical trainees and data collected online via a Google form and assessed via SPSS. The demography of the results, so sample size is quite small, 60, with a gender distribution of 97% being males and 3% being females, and mean age being 31.2. Most of them are first-year surgical registrars, and previous exposure as a medical officer or senior house officer was seen in 54.5%. Regarding the performance anxiety, 94% felt that SPA affects surgeons in general, and also 94% felt that it negatively impacted surgical outcomes. 97% also thought that it affects surgeons' well-being. In our population, 66.7% are currently experiencing surgical performance anxiety, and 24.2 has previously experienced anxiety, but 9.1% has never experienced anxiety. Most of our participants who had experienced SPA or are currently experiencing SPA did so before surgery, followed by during surgery and after surgery. We went on to analyze what are the SPA triggers, and we found that at least 64% of the respondents had at least one trigger. So most common triggers, I have highlighted the 5 most common triggers, which are a specific senior, a specific surgery, a lack of experience, assisting theatre staff, general theatre environment, and time. And I have thematically analyzed those other responses in the diagram, which we have divided into technical, environmental, and non-technical. And then we went on to analyze is there a specific technique among the trainees to overcome this SPA, and these are the 5 top comments that they brought forward. First thing is practice. Second thing is training and repetition, senior consultant support, talking to peers, and self-motivation. And then there are other techniques which they have responded in minor amounts, which I have diagrammatically explained to you in that chart. So regarding communication of SPA, of the trainees who had SPA, only 9.7% shared it openly. So that means the rest of them, either they have confided it to some close person or close relative, or have kept it to themselves. So 38.7% have actually kept it for themselves. Regarding interventions, 49% only reported a technique for overcoming it, and only 26% reported that whatever the technique that used is actually effective. So rest of the group who had it actually don't have a technique to overcome it as well. 3% surprisingly reported using medications for SPA, and 3% sought psychological counseling. Then we went on to analyze if there are any predictors of SPA, but however, we couldn't find much predictors as in the UK study. They have found that gender and performance anxiety, there's a significant predictor of SPA, and the number of median years as a surgical training also. But what we have found is that SPA and previous surgical exposure has a predictive outcome. That is, trainees who had a previous surgical exposure are less likely to develop SPA. Then we found that there's a significant low mental well-being scores associated with trainees who ever had SPA, that is the trainees who have already experienced it, or the trainees who have had experienced it in the past. So there's a significant correlation between low mental well-being outcomes and SPA. So as conclusions, we would like to demonstrate that there's a high prevalence of SPA among surgical trainees, and majority of them did not use a portal of emotional ventilation, and SPA significantly affects the mental well-being among trainees. So we are recommending a more open culture of sharing and discussion, and support systems are recommended. Limitations, we need to assess this in a wider population, and in the population who has had previously experienced SPA has had a risk of recall bias, and very few trainees at the end actually gave the consent to actually participate in the study also, and there's a lack of willingness to disclose SPA among trainees as well. Thank you very much.
Chandragupta, now the paper is open for discussion.
Dr. Chandragupta, in the light of your last comments anyway, can you clarify the methodology? Was it questionnaire based? Did they fill the questionnaire, or did you speak
No,
to the...
they filled it. It's via online Google form. We sent to all the trainees, and they filled it by themselves.
Okay, and confidentiality was assured?
Yes. It is an anonymous form. You don't have to give the names.
Yeah, I really like this very small study that you've put together. So there was one parameter about a specific surgeon somewhere.
Yes.
And so I don't know whether it would be possible in your data to find out what happened if that particular surgeon was removed from that patient's, that trainee's environment. No?
No, we didn't ask such questions.
You didn't ask that question.
Sorry.
Well, it's a very good effort. Thank you.
Thank you very much.
One more question.
Sorry. I think you said that all of the cohort were first year?
No. Majority were first years.
Did you do any sort of subgroup or comparison?
Yeah, the problem is there's no
significant.
Yeah, the sample size is small, so 60. Majority of them, I think around 80% were first year registrars. The rest was small numbers. I think we have to do it in a more elaborate study involved in the national wide studies. I don't think we have sufficient second year, third year registrars to actually interpret.
Okay.
Okay, thank you very much, Dr. Chandragupta. That brings us to the end of this session of trainee best presenter session. I guess all of you would agree we had very good quality presenters today. So the three top presenters today will be awarded travel fellowships kindly sponsored by Association of Surgeons of India. They will get to visit, present their papers at the ASICON that is coming up in December this year, 13th to 16th. In addition to that, they have the option of spending 2 additional weeks in India in a center of excellence, again kindly sponsored by Indian Association of Surgeons. And the top presenter today will get the opportunity of presenting his or her paper, there were no ladies today, at the annual Congress of Royal College of Surgeons of Edinburgh that is going to happen next year. And the IR fair also will be partly supported by the College of Surgeons. So we will let you know soon who the winners are. A few more now.